Okay, well, let's make a start then. Thank you all for coming. Well, Happy New Year. It's the last time we did, I think, only in the autumn, our last meeting. Welcome to the Dementia Open Forum, where we're hoping to present new projects or findings from dementia-related projects happening at UEA or partners. So it's my great pleasure to introduce today Dr. Jane Cross, who's an associate professor at the School of Health Sciences here at UEA. And Jane is going to talk about one of their projects called Splendid, Social Prescribing for people to live enjoyably with dementia in daily life. If you have any questions, I'm sure Jane will be happy to answer them later. So hold back until she's finished, and then we can go through your questions, which you can either tap in the chat or you come online and then ask your question. So thank you for coming today, Jane, and over to you.
Thanks, Michael. Good afternoon, everybody. It's really nice to have been invited to talk about Splendid here in this particular venue. I will just say that I'm recovering from flu at the moment, so if I have a coughing fit, I will just turn my microphone off so you don't all have to listen to me, but just give me a minute if that's the case. We're going to talk about Splendid today, which is an NIHR program grant that we've had running for not quite 12 months yet. It's led by myself at the University of East Anglia and Professor Chris Fox, who is a professor at University of Exeter now, in case any of you haven't realised that he's not here anymore. And it's sponsored by all these particular people and in partnership with Norwich and Waveney Partnership. So I'm going to talk for about 30 to 40 minutes, depending on how it goes with coughing, and then I'm very happy to open up for any sort of discussion, and we'll go from there. So what is social prescribing? Well, I'm assuming some of you have come along because you all know what social prescribing is, but for people who don't know what social prescribing is, social prescribing is something that's been going on for a long time in various forms, mainly in the community and voluntary sector, but it's something that's gathered a pace in NHS reform and NHS provision and plans for delivery of meeting healthcare needs. It supposedly helps people by connecting them to community resources and supporting them and empowering them to do things to improve their own health or well-being, and it does this by strengthening community connections. Now, social prescribing is facilitated by a person who works with the individuals who've been referred for social prescribing to facilitate them to access things that they want to do. That is a rough overview, and I'll come back to how the definition of social prescribing works. But that's what social prescribing currently is. And Splendid is looking at social prescribing because it wants to develop a way that people who are doing social prescribing in health, social care and community and voluntary sector might work with people with dementia and possibly their significant others to engage with activities that they might continue to enjoy. And Splendid is looking at ways that we could achieve that, and I will talk a little bit more about the reasons why that might not be obviously the case in a moment or two. So this is a little bit of background for you. Massive population of people in the UK with dementia. That number's growing, and that reflects the state across the world. So in the guidance for caring for people with dementia, it states that they should be offered tailored interventions, including non-medical approaches such as lifestyle interventions and social support. Healthcare systems struggle to respond adequately to this because there is a growing burden here of complex needs, and we'll come back to that complexity in a bit. In the absence of tailored support, these complex needs are associated with increasing isolation, and they can also be inappropriately medicalized. So we need different approaches to managing these complex needs, and it is suggested that social prescribing is a way to deliver that. So Splendid sets out to investigate whether a co-designed social prescribing pathway for people with dementia can provide benefit and is implementable in current health and social care systems. And there's a number of nuances in that question. We are co-designing because we believe that people who are experts in this particular area, including experts by experience, are the best people to be involved with developing the way in which they could connect with social prescribing and social prescribers. We have been very careful not to very precisely define what benefit means at the moment. And when you see the work packages, you'll see that's part of the work that we're currently undertaking to define what that benefit might potentially be. And then we're asking a very important question about implementation, because with complex interventions such as this sort of a pathway, implementation into current health and social care contexts means that there are lots and lots of different situations. There are lots of different implementation contexts within which you are asking such an intervention to operate. And that requires looking not just at the intervention itself, but at the context in which you're asking it to interact with and be part of. And in order for it to be effective, it has to be implementable. So that's why there are a number of nuances in that particular question. So what is social prescribing? This is a very busy slide, and I fully appreciate it's a slightly difficult slide to come to terms with, but I will talk you through it. The reason I'm using this slide is because there's been a recent piece of work from Mahil and the others credited at the bottom of the screen, where there is also a document ID for this publication. And this is the latest work to produce an international definition of what social prescribing is. And we are currently using this definition of social prescribing in our work. So social prescribing involves somebody who is it involves an identifier, and this is the person who might say that these individuals have a non-medical health-related need, and that's starting at the top left-hand side of that particular slide. And that person refers to a connector. And in this international definition, if somebody is working in a social prescribing role, then they would be the connector. But we'll talk a little bit more about the complexity of this particular situation, because there are lots and lots of different versions of how this connector may operate. And what we've learned in the 10-11 months that we've been working is that there isn't a universal person who might perform this connector role. And I'll talk a little bit more about that again in a minute. Now, the connector works with the person who has the non-medical need, and that connector helps them. They work together to develop a shared understanding of what it is that they need, and then to identify particular opportunities that may meet those particular needs. So, for example, if we think that the person with dementia wants to continue to enjoy hobbies that they've had pre their diagnosis, and we can identify that hobby perhaps as cycling, then it would be the connector's role to identify a way that the person with dementia could continue with that particular activity in a meaningful way. Apologies for that, in a meaningful way, so that they can continue to enjoy that aspect of their life which has formed part of their well-being. The connector might need to actually go to the activity with the person to introduce them to a new group, or to make sure that they are being welcomed in that particular group, or they may not. And that again is part of this flexibility of the connecting role. But they would need to follow up with the person with dementia to see if that particular connection has worked out for them, not worked out for them, not actually been what they wanted to do in the first place. So there's a circle here of going back and checking to see what's happened. And they also would need to liaise back with the identifier, so the person who's identified this particular non-medical need. And the idea of this partnership with both the person who's been identified and the connector is that you can improve the health and well-being of the individual and strengthen their connections into the community. And that is what is in this social prescribing model going to address their particular non-medical health related needs. So the connector role is absolutely key in this particular definition, which is what we're using for our work. So I'll be going back to this throughout what we're talking about. Now, the reason I say there's so many differences here is because the NHS jumped on the social prescribing method as a way to solve issues related to primary care, not being able to deliver the sort of services to the volume of people that require these particular interventions. So it's driven by this recognition of some needs that people have that they go to primary care for are non-medical, and that they don't need to be medicalized. And so in recognition of that, they introduced into GP practices social prescribers working in that particular setting. But obviously a social prescribing service is then available to all of the people registered with that practice. And as you can imagine, those particular people performing that particular role will be very quickly swamped with need, because they're going to be the way that people who are going for GP appointments are going to be signposted to the social prescriber when there is a non-medical need identified. And that's going to be quite a common occurrence in primary care. Now, the feedback we've had from working with our social prescribing networks and working with social prescribers themselves is that this means that the people acting as social prescribers are very quickly overwhelmed with need and people to see and to deliver to. They are also, because there is so much emphasis currently on social prescribing and it's seen as a very exciting aspect of health and social care, there is also tremendous interest into what these people do. And there are lots and lots of researchers doing exactly, well, not exactly what we're doing, but similar things to what we're doing in different projects. So they're also, not only are they overwhelmed by their workload, but they are also overwhelmed by research people like ourselves who are coming in and asking them for information about what they do and how they do it. So this service then can actually be very overstretched and very stressful for social prescribers. The other thing that's going on is that social prescribing, of course, means that some of the people that are going to be referred to this service have incredibly complex needs. And they can have incredibly complex needs involving complicated families within complicated contexts, and potentially lots of more serious issues where there might be safeguarding concerns or wellbeing concerns that quickly escalate. And the social prescriber then is in a situation where they're responsible for incredibly complex care needs, adding both to the pressure that they're feeling and the pressure that they're experiencing within that particular role. So it's a difficult role. The other thing that we've learned as we've been through part of this process, is that these aren't the only people who are doing social prescribing. There are lots of other people, not necessarily called social prescribers, but called other things, that may well be part and parcel of other community-based services. And we've identified some of these. Some of them are called, sometimes they're called things like community connectors. They might be community matrons. They could be particular people attached to particular services. And one of those in Norfolk, in NCH&C, they have people working with very frequent attenders of both A&E services and general practice services. And those people are called high intensity user connectors. And when you look at what they're doing, their role very much fits this particular international definition of social prescribing. But here, as we clearly identify, they're not identified as social prescribers, although there is so much overlap, it would be impossible to ignore them from this particular sort of work. So when we started this particular project, we thought that it was going to be relatively simple, in that we would be looking at social prescribing going on in primary care settings with people identified in job roles as social prescribers who operated out of general practice settings, and that therefore planning a pathway would be a relatively simple thing, and that we would be able to implement it easily into the context because we knew what the context was. And what we've learned in the first 10 months is that none of those facts that we began with are necessarily the same as they were when we wrote this application. So we've had to do a lot of work in this first part of the programme to broaden up our understandings, to work with this new international definition, and to lead this work forward in a way that it might well connect with the current implementation settings that I've spent a little while outlining here for you. So going back then to Splendid, we our programme plan was to design and implement this novel, co-created, blended approach to social prescribing for people living with dementia. And you might ask yourselves, why people with dementia? Why are they particularly problematic? Well, it goes back to how social prescribers were set up in general practice, in that as I said to you, there's a large range of people in general practice contexts that might well be referred to social prescribers. And there'll be lots of people with mental health problems. There'll be lots of people with physical health problems that could benefit from a more lifestyle approach, like some of the cardiovascular diseases, like diabetes, like osteoarthritis. And quite simply, people who are going to social prescribers with those particular problems are probably a lot easier for the social prescriber to deal with in a way that fits with the way their role has been set up. And that's twofold. Firstly, it's probably easier to work with them to understand quite simply what it is that they need and want, and how services that are currently available might actually deliver those particular needs and wants. And some of that is also drawn from the fact that within the community and voluntary sector, there are lots of groups that exist that seem to map quite well to some of those pre-existing conditions. And groups that map to people with dementia's wants and needs may well be more difficult to access. And some of that will be because not everybody with dementia wants to go to a group that is specifically for people with dementia. Quite a lot of people, particularly those who are newly diagnosed, will be wanting to maintain hobbies and interests that they have had pre-diagnosis, and they would want to use those as their community connections. So those groups may or may not be available and accessible once that person has that dementia diagnosis. So there is much more complexity potentially for social prescribers trying to prescribe for this particular population. So once we've designed and tested out this particular co-created blended approach to social prescribing, we wanted then to test it in a feasibility trial, and it was going to be cluster randomized, and then to take a full-scale trial of efficacy of this particular pathway, and then obviously to disseminate findings. So those are the objectives that we began this program with. Where we are at the moment is still bullet point 1, which is designing and potentially then implementing this novel co-created approach to social prescribing. These are the work packages that we designed to do it. And as you can see, with this sort of program approach, there's lots and lots of facets to the work that we're doing. It's not a simple one question, one answer type piece of research. So the work packages run into each other, as you can see, work packages 1, 2, 3, and 4. And then there are cross-cutting themes. So work package 5 is a cross-cutting theme that runs through all the other work packages. And this is to address inequalities, diversity, ethnicity, inclusion, because when we designed this particular program, we are particularly aware that not only are services for people with dementia difficult, but services for people who live in areas of great inequality, areas of great diversity, certain ethnicities, add particular problems and more complexities to the social prescribing equation. So we particularly wanted to address that throughout the programme. And so work package 5 runs through all the other work packages, taking that particular aspect of, are we addressing inequalities? Are we meeting the needs of inequalities? Have we considered ethnicity? And that runs as a theme all the way through the programme. The other aspect that runs through the programme is the health economics, and that's because obviously with all of these NIHL programs, you often need to address health economics. Is this sort of approach cost effective? Does it not only does it work, but is it cost effective? And the cost effectiveness aspects will be tested in work packages 3 and 4. But in the beginning, in work package 1, we've got health economics currently underway, which is looking at developing discrete choice experiments. Now, I'm no health economist, but my summary of discrete choice experiments is that it asks the question of, if you were to receive such a thing, how much would you theoretically be prepared to pay for it? And would you be prepared to pay more for it than something else, or less for it than something else? And those are the questions that our health economists are particularly answering in the programme. So as I said, we are currently embroiled in work package 1, which is taking quite a lot longer than we had potentially mapped out in our programme, due to the changing nature of social prescribing, the changing nature of the social prescribing provision across both health, social care and community and voluntary sectors. And so the outcomes of the programme are exactly as we set out before, but some of our methods have differed from originally what we proposed. So we were planning on mapping out the national context of social prescribing, and that piece of work is currently underway. The reason for doing that is to understand exactly the context within which you're hoping to implement your intervention. And you are using it as a way of identifying early barriers to implementation, because as I outlined earlier, this implementation, the implementability of a complex intervention is key to whether you can assess any effectiveness. It also was to inform the sampling for the other parts of the work packages, because you've obviously, when you're trying to implement a new intervention, you've got to push against an open door. So understanding that national context of where there is social prescribing going on, who is doing it, how it's being done, who it is being offered to, we would want to do the implementation work within the door that is available to be pushed open to let us into those particular contexts. So that work is currently ongoing. The second part of work package 1 was to use something called experience-based co-design to design exactly what the intervention needs to look like. And we are currently starting this particular aspect of the work. The reason that's been delayed will become obvious as I discuss the other elements of work package 1. But in experience-based co-design, you use experts by experience in order to help us as researchers design how this particular pathway needs to look. Now, experts by experience are both people with dementia and their significant others who help them negotiate this complex world where they're trying to maintain some shape of their identity and keep some social connectedness. But it also involves experts by experience of the social prescribing itself. So that is social prescribers, people who are working in roles that would meet that international definition of social prescribing but aren't necessarily called a social prescriber, people who commission services for social prescribing or commission services to provide this community connectedness, as I said, to link back to what I said earlier about how this international definition is so important. So we will be working with those particular people, and our plan is to do that in areas where we already, from our mapping exercise, know there is an open door that we can push into to plan the implementation phase, which is going to come next. As I outlined at the beginning of this talk, defining exactly what effectiveness means for this population with this particular intervention is again open to interpretation. So work package 1C was about determining what are the appropriate and valid social prescribing outcomes for this particular population. And this work is currently being undertaken by our Newcastle leads who are part of our programme, and they are currently working with focus groups of people living with dementia and their significant others to identify what it was that they would need from and want from social prescribing. And we are using a core outcome set that's been developed by another research group, which is looking at non-medicalized interventions for this particular population. And what we're aiming to do is map the core outcome set onto the outcome measures that are available, and then ask the people living with dementia and their significant others to look at those core outcomes to inform what might be the most appropriate and valid outcome measures. So that's quite a complex task here, but that is currently underway. Now I'm going to skip and jump to work package 1E because this is the piece of work that actually kicked off this whole particular work package. And this is a complex intervention systematic review of social prescribing using that international definition that I spent some time talking about as the premise for how we're going to do this particular type of review. Now, in our original proposal, we had talked about doing a systematic review. But if you look at and there is such a systematic review, which we are currently updating with the Newcastle team and which will be out for publication fairly soon. But with a standard systematic review, where you look at RCTs of this particular sort of intervention, the pool of literature that you can bring into this review is very small. And therefore, the findings from the review are very limited. So although that piece of work is going to be part of what we deliver from the programme, we needed to expand that to understand in a much broader context what was out there in the literature about social prescribing. And this is why we've undertaken the complex intervention systematic review. The protocol for this review is currently under review with BMJ Open, but my team are currently quite a long way through the screening. It's been a massive review with an awful lot of papers, and the team that I'm working with are currently a long way through the process of bringing all that literature together, and they're about to begin undertaking, or they're some way through undertaking, the synthesis now of this particular review. What this review will begin to highlight, I suppose I'll just take a step back for a second. So a complex intervention systematic review was new to me, and it was brought to me by members of the team that I'm lucky enough to work with. What it does is it takes a systematic review methodology, but it begins with a much more open question, which has a logic model attached to it, which begins to identify what are the components, context, mechanisms, etc., of apologies, I got quite a long way through without having to cough, so I thought I'd done quite well, but I just had to pause there. So the context, mechanisms, outcomes, CMOs of the particular intervention here are what are being mapped into the logic model. And so we bring the literature together then and can identify these the context, the mechanisms by which social prescribing may be thought to operate, and the outcomes that are thought to be particularly important here. So what it does is it very nicely bridges both the mapping of social prescribing and what's going on to this particular population, and it also brings us information about outcomes that might be important and valid in this particular intervention for this particular population. And so bringing work packages A, B, C, and E together then brings us to what might then become the pathway. And once we have that identified, then we will be able to then develop the handbook and training packages for the staff that will be implementing and using the pathway in their contexts, and we'll be able to look at the fidelity, etc. So all the next steps that you need to take that forward into a feasibility trial, and that's what work package 1D will deliver. So as I hope you can see, and I hope I've been reasonably clear, the actual program, the beginning of this program itself, work package 1, is actually a rather complex piece of work, which is having to bring a number of strands of work together in order to develop something that we can call a pathway specifically for people living with dementia, to enable them to have better community connectedness that fits that particular international definition of social prescribing. So this is our little handout that actually has been manufactured as an A5 leaflet, and we're using this to hand out to lots of people in the community and for our PPI work, in order to talk about what Splendid is and how it might be working, and also to get people to be interested in working with us. We can't do this work without a whole massive group out there from all sorts of stakeholders, and there's stakeholders in all the important groups for dementia, so Alzheimer's Society, Dementia UK, etc. Then there are all the social prescribing networks, and there's lots of people involved over there, as well as people living with dementia themselves and their significant others. And I'd just like to finish by acknowledging the enormous number of partnerships that we have in order to deliver this particular piece of work, and acknowledge our funders, which are NIHR and obviously Norfolk and Waveney Integrated Care Board, and in particular my colleagues in the Norwich Clinical Trials Unit, who are being absolutely amazing, bringing work of this complexity together. So I will stop sharing here, and then I'm very happy to open for discussion, questions, and a number of members of my team here are here. So if I run out of things to say, I'm sure there's plenty of other people who will jump in.
Fantastic. Thank you very much, Jane, for this comprehensive overview of Splendid. Clearly complex, so I congratulate you for tackling that complexity. We have a hand up already, so Amanda, please go ahead, Amanda.
Thank you very much. Nice to see you, colleagues, and thank you, Jane. Some of you may remember that I was a GP as well as an academic at UEA, and one of the things that's really always interested me, because I chose that job to try and be upstream of acute illness. I like the idea of preventing and intervening early and diagnosing early and so on. And I like the variety and the people. But, you know, I've looked increasingly with colleagues throughout my career to find ways to tackle that other upstream, the, you know, social determinants of health, but also the social intervention. So I was very pleased when social prescribing came in, and I applaud the idea of trying to evaluate it in a user-friendly way. 3 comments, and they're probably quite superficial compared to the depth that you've just described. But in terms of the messages that we're giving to people, I think we need to be careful that social prescribing isn't seen as an automatic solution, because there are 2 groups of people who won't use social prescribers. One is the people who, you know, struggle to engage, and the things you said that, you know, you must evaluate, but also there are people whose significant others can work the system for them. And in a situation where there are reasonable community resources and people know their way around them. So I think to evaluate out of those users who volunteer, you know, not necessarily whether they use social prescribing at all is quite important. And then with the social prescribers themselves, I've already heard colleagues saying, I hoped that I'd be able to work up at the community level. You know, if I've got a lot of clients who've got the same problem, I would like to be able to discuss that with the local voluntary agencies or the council or whatever. They're getting, just like GPs, so caught up in the individual caseload that they don't have the time or the space, or indeed perhaps the authorization to go and work upstream. So I think evaluating what else they feel they could do for this community that isn't part of the actual job they end up doing is an important part of the evaluation. And then the third bit that struck me is the outcome when you were saying, you know, complex intervention analysis. I think the before and after is really the thing, whether it's the data from the practice that shows that this person stopped coming because of distress and, you know, getting lost in the system, even if they're coming for other things. So it's not just the number of times they attend, but why they attend. But that should be available from coded primary care data. And then also the satisfaction, if you like, of the person and their significant other to say, you know, this service has done us a favor. And I know that's in the evaluation, but I think in terms of outcomes, those simple, quite simple things, satisfaction and core data about services used, may really be very telling. Thank you, Michael.
I think you're absolutely right. The complexity of this situation is actually huge, and I think social prescribers themselves are currently fairly overwhelmed with the volume of work that is being pushed their way, and also can be incredibly overwhelmed by the sheer complexity of the work they're being asked to do. We are incredibly aware of both those facts in thinking about this as a particular intervention. And I'm certainly collecting the stories of social prescribers with the complexity and quite very incredibly difficult decision making that they're having to make, and the significant amount of responsibility that they're having to take in working with these particular populations. And when you bear in mind that they're employed at band 4, band 5 in the NHS, it is practicing probably way beyond that banding with that level of complexity in their case management. So very aware of all of those things. And you're absolutely right, Amanda, there is a lot of routinely collected data that we can use, and service satisfaction is going to be a massive part of evaluating what happens here as well. You're right.
But it's also just a quick comment. It makes me remember it's a very intimate relationship, isn't it? If you're seeing people recurrently in their home, taking them to places, you know, as a GP, those patients, you know, had an impact on me. But it was rare that I would spend so much time with somebody, and in the midst of the phase of distress, if you call it that, that is very demanding. So yeah. Thank you.
Absolutely.
Great. Yeah, thank you. Great comments already, and highlighting the challenges clearly with that. I just switch quickly to the chat and then I come to Joe. Martin is asking if you're happy to share the slides, Jane. Would you be happy to do that? Great. I think Dan, maybe if
Dan
you
can do that.
Yeah, we can do that via Dan. If you send them to Dan, and then Dan, if you could put in the email address underneath, Martin, if you could contact us via that, we can send you the slides. And Russell is asking, are you consulting with Alzheimer's Society? Or see, Chris already replied to this, and you already mentioned that as well, Jane. So Annalise, if I could come back to you, and first, if we could, Joe, if you want to make your comment or ask question, please.
Yes, it's just a comment, if I may. I've been a carer for most of my life. I volunteer now. 15 years of them caring time was with dementia. Just making a few comments really from the carer's side and the loved one's side of things. And in terms of Wales, I can't really comment for England. Wales have been doing social prescribing now for quite a few years. I think you would find many of them, of the loved ones and carers, are doing social prescribing, which covers many things, really. I think it's essential to go by their guidance as it is for them to go by the groups running it. The information you could gain from that, and what would be any problems you could see coming with particular social prescribing. Would they be up for it? How would they be with it? The information and knowledge you can get from that is immense, really. I think that would I wouldn't say that was going to solve every problem. It could save many problems working through it that way. Yeah, it's just a point I wanted to put forward. Thank you for your time.
Thank you, Joe. Jane, do you want to comment on existing services that exist, well, in Wales?
We are pushing forward in various directions, and Wales is part of what we're looking at in this particular programme. So it's always interesting to understand how these services are evolving and working in different contexts and different settings. And as what we probably will be doing is actually defining our intervention quite broadly with a number of different statements which the intervention has to match in order to be considered part of the intervention. But our plan is to make that quite locally contextual, because it's quite clear that social prescribing is being delivered in so many different ways across the UK, and the localization of service delivery is making the broader standardization of any sort of complex intervention much more difficult, because complex interventions have to operate within a difficult context. And as services are developed on local levels, on local guidelines developed by small local groups, it makes that overarching sort of, you can't do a top-down approach of an intervention. You've got to develop something that will work within that community context. So getting those partnerships on the ground is really important. So thank you, Joe, for those comments. And certainly we will be looking all over the UK.
Great. Thank you, Jane. Annalise, do you want to come on and ask your question?
Yes, please. Can you hear me? Yes.
Yes, you're a bit faint, so if you could speak a bit up, that would be great.
Okay. We have a social prescribing team in our local district council, and actually I sit in all of the meetings that they have on a weekly basis, hoping there'll be a referral for me. We have a day centre here in Sheringham. What we find in terms of sort of social prescribing is people come to us who living with dementia almost too late to really benefit from a day service, and also for the carers to get much respite. We don't seem to have people for very long, and I just wonder why we're not getting people sooner. I know part of the issue is that if they can't afford to pay for themselves and they need social services funding, then they have to go to a whole social services assessment. And that again takes time, and maybe they won't be funded, I don't know, because they might feel they're not, dementia's not advanced enough, whatever. But that is an issue for us, that we feel that we should be getting people much sooner than we're getting them. And they can be enjoying all the stimulation that we're providing in the centre, because we really are geared up to support people with dementia. And the carers get such a break too. I don't know, is it going to speed up the process or slow down the process?
We hope it's going to improve accessibility to services. That is absolutely critical to our mission in the particular programme, because we perceive that social prescribing is probably at the moment very underused for the dementia population, and that would include people in the very early stages of the dementia, when they're first going for memory clinics, etc. So we are particularly keen to highlight the fact that whilst people are perhaps still early in the process of dementia, that there are measures in which their social connectedness can be addressed and social connection maintained, with access to groups, hobbies, maintaining those particular aspects of life for as long as possible. Absolutely.
Yeah. I just feel that I know that what we're doing does enhance people's lives, and I just wish we'd heard about them sooner.
Yeah.
Absolutely.
Thank you for your question, Annalise. We have another raised hand. If you want to come on, please, and ask your question or make your comment.
Hi, yeah, sorry, my name's Emma. I work for the Integrated Care Board. I lead the dementia work in Norfolk. I don't want to take up too much time because we have got Chris coming along to our meeting in March, so we're really looking forward to that. But Jane, I just wanted to make a couple of comments, because I'd shared the information around to the group, including our patients and our carers. One comment they had was, there is still, unfortunately, a stigma attached with getting a diagnosis of dementia. Some people still feel that, why will I want to go to the doctors, because there's a limited amount of treatment, and I think they very much think of clinical treatment. So they just noted that you had to have a formal diagnosis of dementia to take part. I just wanted to share that with you, really, just for a bit of consideration. The other thing, picking up on Annalise's point, is in Norfolk and Waveney, We do have a commissioned pathway that we're working on as a group at the moment. But when patients are referred to the memory clinic or the dementia clinic, as it will be known, there should be a referral at the same time to the 3-tier service provided by the Alzheimer's Society and Dementia UK and Norfolk and Suffolk Foundation Trust, to reach out to all of those patients and carers, and then link with the wider system, including the social prescribers, to collectively use our resources to support them, because obviously the numbers are quite high and our social prescribing and link worker numbers are quite low. But I was just wondering.
Oh, are you still there, Emma? We might have lost her. Oh dear. Let's see if Emma's coming back.
Necessarily for the 60 months.
Oh. Oh. Let's see if she's coming back, Jane. But yeah.
No, she just literally got to her question, didn't she?
Hello, can you hear me?
Oh, are you there, Emma?
I am, yeah. Hiya, can you hear me?
I'm sorry,
now?
we didn't hear your question. Could you repeat it, please? Sorry.
That's okay. So the final question really is around funding, whether there's any funding linked to the research to actually fund those people who are then going to deliver the interventions, because the system, we're really always concerned that a lot of our fantastic partners are not substantively funded posts. So many of those are not due to be with us for the 60-month period that you're referring to as part of the research project, as much as I hope that they will be. I'm just wondering what risks exist when we're thinking about that really valuable workforce.
So looking forward into the trial aspects, which I think is what you're asking about, there is funding that was developed through the Norfolk and Waveney ICB research support to support the service delivery, yes. Whether that, I don't think a question about the complexities of that funding is probably appropriate to go into in too much depth here. But in short, there is some funding available in order to repay those services for the time they spend doing research for the research project that will supplement the clinical service supports, if that makes sense. If you've got more questions on that, then I suggest you talk to Lucy Clark, who's the programme manager and is on this call currently, about the way that that funding will work.
Great. I hope this answered some of your questions, Emma. So we just have some comments in the chat. So Joe just said that many carer groups have taken on social intervention. And Russell is saying there's little or no connection between memory teams and clinics making diagnosis and community support. This is why other people are missed or the dementia has progressed. So Chris, do you want to comment on this? Is this your hand raised?
Well, it's a bit of both, but in the last year, we've been bombarding social prescribing, mainly due to me, because I work in the city team and I mentioned Splendid, and now everyone, it's a routine, so probably overloading them. But I think that in certain parts of NSFT, they do. The trouble is it's overload because the team is massively overloaded in memory services. We have a lot of sickness across all divisions, medics, nurses, and my waiting list is 8 months to get a diagnosis. And I only run a clinic once a week or so, but others it's the same. So it's supply and demand is a problem. The other thing I would add to Emma is that's one thing we're going to be looking at, the costs, because there is no control over how social prescribing is funded. They haven't properly modelled it, and the people at the top are trying to work it out. And the NASP has published a report on the value of social prescribing and how how it is cost effective in a very dodgy way. So this is why we're doing the research, to try and tease out more with our health economists and discrete choice experiment what we're prepared to pay for, because a lot of the providers, as you say, Emma, are just charities and they can't cope with this sort of thing if there's not money to follow. And we know that quite acutely because services pop up and pop down. So That's part of what we want to gather information on in the health economics. How much do they actually need to keep the system stable, or else it'll just fall apart and break like the NHS is unfortunately at the moment.
Great. Yeah, thank you for your comment. Jane, do you want to add anything? Or Emma, sorry, do you want to come back to that?
I don't know if I dare, because when I speak, it seems to break the audio. No, so I've just put a note in there to say thank you to Jane. I'll get in touch with Lucy, but also to Chris. Like you say, it's just I do sit in lots of meetings where we talk about social prescribers. I'm the link for social prescribers in the north, and they are seen as the answer to many things. We did reach out and do some dementia awareness training in North, because again, we're just conscious that they deal with every possible condition that's coming through, and you know, we're really conscious of their health and well-being. So it'll be interesting when you come to the education and training piece around how we support that workforce to deal with the complexities that they're facing. Because say, obviously you referenced the band sort of 4, 5, 6, but we've got huge variation really, because not all our social prescribers are within health. So you know, their mandatory and optional training is very different depending on which provider you're talking to. So probably the mapping around that education and training will be really helpful. Yeah, thank you. Thanks, Michael.
No, I think that's absolutely critical, and that's certainly the picture that we are uncovering. We thought we were starting with a complex system, but we had really no idea how complex this system was. And you're absolutely, and if you think you're just speaking for North Norfolk, and then across the UK, it's just being delivered in a very localized way, in so many different ways across the whole of the UK. So yes, it is providing some difficult research questions for us, and some, but nevertheless, a really interesting and quite all-consuming project, really.
So I'm afraid our hour is over. I've had a very interesting discussion. Dan, if you could put again our email address. If you have any further questions or want to follow up with Jane, please email to this generic email address, and we can forward it to Jane and you get in touch with her. Our next meeting is on the 25th of April, so we'll circulate details for that at that time. Oh, there you go. So Dan is too fast for me in the chat. He's already sent it. But just to say again, thank you so much, Jane, for presenting Splendid, which is indeed complex. I take my hat off to you, and for doing this talk at the tail end of your flu. So thank you very much all for coming, and hopefully see you next time.